We're in your fantastic space with books, with children's table down here, small chairs. You're a psychiatrist, an author, a speaker. I need to make that clear. Can you talk about ADHD, please, and the solutions?
Look, ADHD has been one of the major issues in child psychiatry. It's one of the most common presentations for the last 20 years, since the early 90s. It is one of the most misunderstood conditions of children because the word literally stands for attention deficit hyperactivity disorder. Now, that is something no one doubts, that you can see a child who's got low level of attention. They're all over the place, so you know what hyperactive is. The difficulty comes whether that's an illness or a set of symptoms. So what I usually say, look, if your child had fever, you may give them Panadol and they'll get better with the fever, but you've done nothing for the cause. So in ADHD, there's a whole lot of prescribing of Ritalin-like substances, amphetamines basically, and most children get better. I said, great, it proves nothing to me because we know nothing about the reason for this attention deficit, hyperactivity. So back about 10 or 12 years ago, we wrote a book called Cries Unheard and renamed the same acronym as attachment disorder, not attention, and hyperreactivity, not hyperactivity. Now, hyperreactivity is one of the hallmarks of a traumatized child. It's what you see in Vietnam vets, Gulf vets. Hyperreactivity, for a sudden noise, they have a massive reaction. It's because the brain architecture has been changed by trauma. So the parents say, but my child's not been to war. I said, really? Family war? Relational trauma? Wow. Now, once we get to that point, we start looking at some of the different causes of attachment deficit, where there's no regulating of the child, and hence no attention. It's 1 + 1 = 2. Cause and symptom, you treat the cause. Back to why is the attachment so haywire? What's the single thing in a message is to give recognition to the power of trauma and the power of witnessing the trauma. If you miss out on that, you've missed the boat.
Does a light bulb go on for parents? It's like, oh my gosh, you know, what's going on in our family, or that you know, trauma that I have is impacting on my children. Do they get that?
This is where it gets a little. One needs, I think, to deploy an incredible amount of patience and tact, because the first reaction of most parents is, oh, so you're blaming me, and it's not about blame. I mean, one of the very, very memorable case was a family who came to me after visiting a local professor of child health, and they were ready to get the prescription. And when I asked what's been happening, they said, oh, one of the parents actually had a recurrence of cancer. And that's why the behaviour went like this. So I said, well, what did the professor say? She said, well, that's interesting but not relevant. And I thought, oh my goodness, how can a child's relationship to a parent who's being hospitalised, intensive care, not impact on him? I could not make sense of it.
No, we're emotional beings. I mean, we know that. So from this work that you do you find that parents are always receptive to this?
No.
No. Okay. Why would that be, do you think?
Well, parents shouldn't be receptive to a stranger getting involved with their family life. It's most natural that there should be a boundary, and you're outside and we're inside. So you really need to get permission and gain permission and slowly build some level of trust that you're acting on behalf of the family.
And how do you get that over then to the mother or the father? I don't want this bloke involved with my family.
Well, I'm at the end of the line of desperation calls because a parent usually has consulted their family, uncles, aunties, grandparents, cousins. That doesn't work. They go to school and the school counsellor. They go to their GP. They've had OT, occupational therapy, sometimes visual testing and hearing testing, and it's all normal, and the child's still not behaving, then finally someone says, I think you need to go and see a child psychiatrist.
You work with groups of up to 10, I believe.
Well, with families, and sometimes if they have, say, 10 or more children, then there's a dozen people.
Yeah.
So because an assessment of a child is essentially an assessment how that child is in their family.
Mm-hmm.
So if you don't see the child in the family, you can't assess that child.
Mm-hmm.
There's no such thing as a child without a family. It may not be their biological or original, but no child can survive without adults to provide. And so I have to assess the group they're in.
So how do you work, George? Could you explain how that works on this level of your work?
Well, usually I receive a phone call from either a referrer, a school, a psychologist, a paediatrician, GP, a teacher, saying we've got a concern about a child, or a parent says we've got a concern about our child.
Yeah.
So I arrange an assessment meeting, one of 4.
Yeah.
And in those meetings I meet once with the whole family, once or twice with the child, and then a feedback. That is, I provide what I've understood and assessed and offer my recommendations to the parents and the child or children.
Yeah.
And then leave them a little bit of breathing space to decide what to do with that.
Nice. Yeah.
And then, you know, whether it's individual therapy or treatment, or family therapy, or parent therapy with one person and the child with someone else, plus or minus medications if there's indication. And so that's the formula, as it were, for child psychotherapy, psychiatric treatment.